Hello everyone, welcome to this quick session of discussion for the latest recalls for part one. We are going, inshallah, to discuss some tricky questions. They are tricky because they are considerably new. Maybe they are not familiar for most of you. They are not really difficult, but I don't want you to feel any depression if you are not being able to answer most of them. This is really normal. Especially if you are depending on your preparation on recalls only. And this is a great mistake, of course. Okay, why I chose those questions? Because they are going to tell us or give us an idea about what else to study. If they like to question us in those points, then I should know the whole picture, or I should be prepared for a similar question. Not the exact one, I mean a similar question in the topic. Okay, let's start. We have this question, for example. By the way, those are the latest 3 years questions from 21, 22, 23. What is the most abundant hormone circulating in females? Lately, they love the questions about the most common, the most abundant, the most serious, and however. So you have to be prepared, and I call them who are going to win the million, or who is going to be the millionaire question type. So in this one, what do you think? You can write in the chat box if you know. If you don't, I'm going to tell you the answer anyway, don't worry. Okay, this will be DHEA. Yes, excellent. DHEA. Because this is the main source of other estrogen types hormones. So that's why DHEA is the most abundant hormone in females or males, by the way, in both of us. But in females in particular, they are the sources of pregnenolone and androstenedione and whatsoever. So until the conversion from the androgens to estrogens. So even if I don't know the answer, I need to think about it. If I know the very famous algorithm for the hormones, for the steroidogenesis, you know what? You are going to figure out the right answer. It won't be ever the active metabolite of any hormone. No, I have to search back, look back. What is the main component of this hormone? This would be the most abundant hormone, even if I don't know the answer. Okay, so for example, if you are thinking of progesterone, try to think a little bit. If progesterone comes from DHA or vice versa? No, progesterone comes from DHA. So no, this would be the right answer. And of course, it's not DHT. Dihydrotestosterone is the active form of testosterone, the most active form of testosterone. They are not abundant in the female at all. It would be abundant in the male, yes. But again, the origin of this hormone is DHEA. So that's why DHA is the correct answer. Can you get what I'm talking about, guys?
Yes, doctor, but your voice is breaking time to time. I don't know what's wrong with her on the side. If you can check it.
I'm not able to hear you clearly. Can you write in the chat box?
Okay, sorry.
Okay, this one also is really great one. I like this question because most of us know, but by far we all know now what is the most common types or subtypes of HPV, the highly virulence one and the low virulence one, which one can cause the warts, which one can cause the cervical carcinoma. But here they are asking differently about the most common infection or a condition that would be associated with differentiated VIN. So this is different. Why? Because HPV is not going to cause differentiated VIN. HPV will cause undifferentiated VIN. So I'm not talking here about HPV virus at all. That's why I like this question. They want to know if you have any idea about lichen sclerosis. Lichen sclerosis is the correct answer here, of course, because it is non-HPV question and it is related to differentiated VIN or DVIN. By the way, the progression to squamous cell carcinoma by something like lichen sclerosis or lichen planus is more severe or more common than HPV. But HPV is the most common virus that can cause squamous cell carcinoma. So that means that HPV is not the main reason why women are having squamous cell carcinoma? No, it's not. But it's treatable, or we can prevent it. And that's why we are offering the young girls vaccination. Once she turned 21, she's going to have a vaccine for HPV. Can you remember the type of HPV that can cause squamous cell carcinoma? Which subtype? (16 and 18). Okay, those are the most famous ones. There are high virulent one also, yes. But 16 and 18 are the most famous. We have 21, 31, 51, and 52. There are many. And the vaccine now is, we are trying to develop it more and more to cover most of the subtypes. The one that can cause the warts, this is very, very common recall. HPV number 6 and and 11. Those are the subtypes that can cause genital warts. Okay, next one. This is not a recall, but something like this appeared before, and my candidates were not sure if this exactly was a recall or not. So let's see it. If they are going to ask about it, we should know it. Which antibody is involved in Hashimoto thyroiditis? Let me ask you the very common question. What is the most common cause of hypothyroidism in pregnancy? Okay. This would be Hashimoto thyroiditis or autoimmune thyroiditis. So, okay, the next question would be, and it's a very common recall also, what is the most common cause of hyperthyroidism in pregnancy? That would be Graves' disease. Graves' disease. Okay, what is the most common cause for hyperthyroidism worldwide? Again, this would be Graves' disease. What is the most common cause for hypothyroidism worldwide? It would be iodine deficiency. So here, because Hashimoto or Graves' disease both are autoimmune conditions, there are antibodies that is involved in this disease. Okay, TRAP is for Graves. TRAP is for grapes. The TPO, or the thyroid peroxidase antibodies, is for Hashimoto. Okay, guys? The anti-nuclear antibodies has nothing to do with the thyroid. The lupus antibodies also has nothing to do with the thyroid. And the anti-cardiolipin antibodies are related to antiphospholipid syndrome. The ANA can be positive in many immunological disorders, like, for example, that can come in my mind now. The fifth disease, what it's called, the rheumatic arthritis, this systemic lupus erythematosus, and so on. Okay, this one is really good, and they love to ask about the different features between premenopause and menopause. Okay, either histologically or in general. So I remember it was in, I think, 2022 January, if I'm not wrong. They asked about some features of menopause in a table, and you have to choose from the table some of the correct features for menopause. Well, I'm going to show you a picture in a minute, but from those, which one is true for a feature of menopausal endometrium? This is very easy. This one is really easy. Of course, it will be the atrophic glands. Okay, they're very obvious, yeah, very obvious one. So those are the features of atrophic or menopausal endometrium. You are expecting to see the glands are atrophic. The epithelial lining now is cuboidal or flattened. The glands sometimes could be cystically dilated, and the fibrous stroma is very scanty, very little, like this. The total opposite is with premenopausal endometrium, or the more you are going back in time for someone who is in the reproductive age, the stroma is going to be abundant. The glands is not going to be atrophic. They are going to be numerous, especially in the secretory phase, right? The epithelial lining is going to be circular, okay? And the glands are not going to be dilated except in the very end of the secretory phase. Okay, that's what I was talking to you about. When they asked about the features that can appear in a menopausal woman, that would be the thin vaginal epithelium, the high vaginal pH. Let me zoom it for you, or you can zoom from your screen, by the way. You can zoom in. If I can zoom it for you. This appeared before, guys. She's going to have a thinner epithelium, thin layer of mucus, of course, because the cells that can produce the mucus is very little now. Low estrogen levels, and that's why she's going to have low glycogen, and she's going to have low lactobacillus bacteria, and she's going to have high vaginal pH. All of those are because of the low estrogen levels. And all of those are the reason why this woman is going to have dry vaginal epithelium. And that's why she's going to have repeated infections. Why? Because the microbiota of the vaginal epithelium, the normal one, which is the lactobacillus, is very low. So the immunity of the vagina is very low. Okay, and that's why, again, she's going to have high vaginal pH. Okay? This is when we have a post-menopausal state. When we give this woman HRT or hormone replacement therapy, we are trying to do what? We are trying to increase the estrogen levels. That's what we can do. So when we do this, or increase the lactobacillus colony in the vagina, if we are able to do this, we are going to reverse all those negative effects. But still, we are going to have a thin layer of mucus, because this is something that is out of our hands. However, the estrogen level is going to be a little bit higher. The glycogen is going to be a little bit higher. So the vagina pH is going to be lower. So I'm expecting to see lesser incidence of vaginal inflammations or bacterial load. And if I'm going to increase the estrogen levels, I'm going to have much better mucus secretion. Okay, so it's going to depend on the dose and the route of the estrogen, either it's vaginal or oral or patches or what. Okay, this also came in the exam before. The question was, you are examining a woman in her 50s or something like this, and when you are inserting the uterine sound, you have discovered that what you are expecting to see. Yes, when you are inserting the uterine sound, what are you expecting to see? That the uterine body to the cervix ratio is 2:1, 1:1, 3:1, 1:2, or what? This is a recall, by the way. A woman in her 50s, I'm expecting that she is postmenopausal, right? So the ratio of the uterus to the cervix is going to be 1:1. Commonly 1:1 or 1:5:1. Why? Because the uterus now is becoming small again, atrophied. Just like a premenstrual female or a pediatric female or a prepubertal female. Okay? But not the neonates. The neonates are going to have big uterus and a very small cervical length. But in pediatrics or prepubertal, same like the postmenopausal state. In the normal reproductive age or the pubertal age, the ratio between the uterus and the cervix is going to be 2:1. The uterus is double the length of the cervix. Okay. This one is really common, and it can come in many forms. Your patient has been taking therapeutic low molecular weight heparin during pregnancy for acute VTE. How much you should wait before inserting epidural catheter from the last dose? Anyone know? Yes, excellent. 24 hours. Why 24 hours? Because this is a therapeutic dose. If it was prophylactic dose, do you know how much we should wait? 12 hours. Excellent. Excellent. This is a very, very common recall, and it can come in many forms. Like, for example, they can ask you why in the first place you should wait. Why you should wait before inserting epidural catheter or spinal anesthesia? Why? Because we are fearing of the formation of hematoma from the placement of the epidural catheter or the spinal needle. So we should wait at least 24 hours from the last dose if it's a therapeutic dose, or we should wait at least 12 hours if it's a prophylactic dose. Okay, another question. If she had been taking therapeutic low molecular weight heparin and she had epidural anesthesia, you just removed the catheter. How much you should wait before resuming her low molecular weight heparin? This one could be a little hard for you because you, I know that most of you have never gone through this guideline. It's 4 hours, 4 hours, at least 4 hours. And here's the trick, guys. Here is the trick for part 1. We are not supposed to know every single details about the management from the Green Top guideline, but we should know the very basics of surgical techniques, the very basics of pre and post-operative care, the very basics of hygiene and antiseptics. That's why if you are a candidate in our course, you are going to find that we always take care of this point to give you hints about surgery and what can come for a part 1 in surgery module. This is very important here. Okay, you should know this. However, they are not going to ask you about details in VTE management or how to calculate the score for a patient who is going to have an operation, or a pregnant lady who is very risky for VTE, how we are going to calculate her score. No, this is not going to appear in part 1. But they can ask you about the epidemiology. Yes, epidemiology is very important. They can ask you about the risk of VTE in pregnancy in general, or the risk of VTE in general population, or the risk of VTE in someone who is using COCs, the combined oral pills. Okay, this can come in part 1. Yes, of course. Okay, so take care. Yes, we are not going to read all the Green Top guidelines in details, but we need to take care of the general lines: epidemiology, risk factors, most common causes, and the general lines of treatment. Like in nausea and vomiting, for example, no one is going to ask you about the details, but at least they are going to ask you about the first line of management. What is the first line of management? Yeah, this could be a question for part 1. Why not? Okay, I brought you the a screenshot from the NICE guideline to help you. Okay, this one is good also. A woman who had a C-section is complaining of an irritating nodule at the site of the scar. What type of cells is found in this type of inflammation? What are you expecting this to be? What is your diagnosis? It could be many things, by the way. But according to the choices here, what are you expecting? Because they have mentioned that this is an inflammation. Okay, so it's now very easy. There's differential diagnosis, by the way, for a nodule at the site of the scar. Okay, this nodule, is it acute inflammation or chronic inflammation? If you have the diagnosis right, you are going to answer this question correctly. This is a form of chronic inflammation, guys. This is a granuloma, a suture granuloma. Okay, so we are expecting, by the way, to see all of those. All of those can be there. However, the most abundant one, or the main one that you are going to find there is what? Is the macrophages. Okay, the macrophages. And here, it's very tricky, and I think this is July 2022. Because they didn't bring the macrophages directly. They brought you the type of macrophages in the skin, which is Langerhans cells. So that's why this question is a little bit tricky. Okay, when you have a foreign body in a scar on you or in the skin or whatever, the body is trying to eradicate it or remove it. Okay, so here we have, what is the foreign body here? The suture or the knot of the suture. So sometimes, even in normal people, not the people who are having hypersensitivity or someone who is having a genetic predisposition to keloids, for example. No, a normal lady, and she's having a Barrett knot, for example. She can have a granuloma. This granuloma is what? Is like, do you remember the granuloma of TB? You remember it? Anyone can remember it? When you have the virus in the center and there are like cells like this surrounding the virus until the virus is dead, and this is going to be a caseating center, and the macrophages on the periphery is going to form the granuloma. This is typically a picture of chronic inflammation. Okay, just like this one. Okay, interesting one. This is microbiology also. The last one was pathology, okay? Your patient is having symptoms suggestive of CMV. Her serology shows the following. The IgG is positive, the IgM is negative, and the avidity index is 0.8 or high. Okay, I'm going to tell you how to crack this. If you know the answer, you can write it down. If you don't know, I'm going to tell you, and hopefully you are going to answer it well. CMV is a kind of virus that can be maintained in your bloodstream for months. The IgM can be there for like 3 months. So once you get the CMV, IgM is going to appear, okay? But it's not going to go away like other viruses. No, this is a special feature for CMV and for parvovirus and for rubella. All those 3 viruses. Sorry. So I'm expecting to see in acute infection, in any other virus, the IgM is going to be positive, the IgG is going to be negative, right? And in any other virus, if the IgG is positive and the IgM is negative, that would mean that the patient is having immunity, right? But in CMV, rubella, or parvovirus, the story is different. Why? Because as I told you, the IgM can be positive for a long time. Okay, here the IgM is not positive. So this is not an acute infection. Okay, this is very easy. Now, can I say that this is immunity to CMV? No, this is not the case with CMV. When the IgG is positive, that means chronic infection, okay, or latent infection, or a post-infection, but not immunity. Why? Because it's recurrent. It can come again, and that's why we use the avidity index. What is the avidity index? It's a type of test that it's going to quantitate the IgG and see whether it's high or low. When we have high IgG, it means that this is a latent infection. When we have low IgG, that means that no, this woman is not having enough IgG in her system. So this is not a latent infection. This is not a chronic infection. Maybe the IgM is going to appear soon. Maybe this could be recurrent infection. So here, if the avidity index is low and the IgM is negative, I would say, number one, she had a post-infection. Recurrent cannot be ruled out. But because the IgG is high, there is enough IgG in her system, and there is nothing of IgM in her system. That means that this is a latent infection. Again, I'm going to repeat it again with this table. What I'm going to look for. First, I'm going to look for the IgM. If I'm having positive IgM, that can be two things. It could be active infection. Now, this is an active infection, or maybe a recent primary infection, because as I told you, it can present or be sustained in the bloodstream, in the system for 3 months. So maybe it's not an active infection, maybe it's a recent one. Or maybe it's a re-exposure to CMV. But I need what? I need positive IgM. If IgM is negative, that can be past infection, no current infection, or latent infection. What latent infection means? Latent infection means that I'm susceptible to have a re-exposure. Yes, I'm susceptible to have a re-exposure. The virus is still active in my system. I'm not totally immune. I told you this is different from any other virus. This is something very special for CMV, parvoviruses, and rubella. Okay? So when I'm having both of them negative, both IgG and IgM are negative, that means that this lady has never had CMV in her life. No current or no post-infection. But if I'm having IgG, that could be post-exposure or latent. How I should know? How I'm going to know this? How I'm going to know if this is a post-exposure and the virus is no more in her system, or a latent infection? From the avidity index. Okay, from the avidity index. If the avidity index is high, this is a strong indication that she's having a primary infection very back, more than 3 months. This is what we call latent infection. Okay, guys? If the avidity is low, that means that, no, this woman is very susceptible to have a primary infection in less than 3 months. Okay? And I don't think they are going to bring you this, because this is going to need another test for confirmation of active infection. You are not going to diagnose it just like this. No, you are going to need another test to titrate the IgM in her blood to make sure that this is not an active infection. I hope it's clear. Is it or not? Okay. This is an epidemiology question, very important one. What is the percentage of risk for pneumonitis in a primary varicella infection in pregnancy? This one would be from 10 to 15. From 10 to 15. Let's see the table, and this table is very important. I always stress on it, because it has, this is, by the way, from the guideline for the diagnosis and management of viral illness in pregnancy. Inshallah, in part 2, we are going to discuss it in details. But now I need you, for part 1, I need you to remember the incubation period, the infectivity period, and this is very important, guys. Okay, and the course of the disease. Is it having a risk of transmission that's increased during pregnancy, or the risk of transmission is decreasing while gestational age is bigger and bigger? Like, for example, here with parvovirus, the risk of transmission to the baby is 0 when you are in the first trimester, and it's coming higher and higher, increasing with the gestation. However, the risk of adverse fetal outcome is vice versa. How? If this woman got the infection from 5 to 16 weeks, the risk for excess fetal loss is 9%. That came before, by the way. This is a report. Okay? Under 20 weeks, there is high risk of fetal loss. And the more you are going through pregnancy, the risk of adverse fetal outcome is low. So there is a difference between the risk of infection and the risk of adverse fetal outcome. This also, I think, came before. No, not this one. I think yes, this one. The neonatal chickenpox risk in the very risky period, 4 days prior to 2 days post-delivery. 4 days before and 2 days after delivery. If the baby got chickenpox or varicella from his mother in this period, there is 20% risk of developing pneumonitis. Okay, so this is really great. This is very big, and that's why if the woman, I'm telling you that just to remember it, if the woman is having active or primary chickenpox in this period, 4 days before and 2 days after delivery, we need to keep her in our watch. We need to keep this baby under observation because he's very susceptible to have fetal varicella syndrome. Okay, and it's not recommended to deliver this baby if the woman is having this primary infection in this period. You are not recommended to deliver her. You are going to postpone the delivery if you can. But if the woman is coming to you in labor and she's having rash, vesicular rash, and when you asked her when this rash appeared, she said just yesterday, just the day before. Oh my God, there is 20% risk that the baby you are going to give birth now can have fetal varicella syndrome. Okay, guys. Again, we can go through the chickenpox because it's very important. Let me ask you, for the management of chickenpox, you need to just remember one thing. If the rash appeared, do you think that IVIG or varicella zoster IG can be given or not? No. If the rash appeared, you cannot give the IG. It has no rule. But if the woman came to you and told you that she had contact with a chickenpox case, and she's now pregnant, of course, and she's telling you, what should I do? If the rash is still not appeared on her, she can have the immunoglobulin. If the rash appeared, there is no rule for the immunoglobulin, and she's going to have a cyclovir and symptomatic treatment like anyone else. Okay. What about this one? Anyone had an idea about the uroflowmetry? If I'm not wrong, this also appeared in 2022. Okay, this is only the uroflowmetry. This is not the whole cystogram. This is only the part of the urine flow. This is, guys, is the normal flow. This is the normal urine flow. Initiation, peak, then decline, smooth decline, or a bell-shaped curve. This bell-shaped curve is the normal uroflowmetry. And in part one, try to be a little bit smart. It's not really common to bring for part one something to diagnose from a uroflowmetry or from a cystogram, except if it's a common case or a very obvious case. Okay, so let's see the normals to know the abnormals. This would be the whole CMG or cystometry or cystometrogram. We are going to insert a probe in the bladder and another probe in the rectum. Okay, and we are going to give the woman IV fluids and see what's going to happen. Normally, this woman is going to have a desire for urination by about 250 milliliter, but she can hold it. She can hold it until when the bladder volume is approximating 400 or 500, she's going to have a strong desire. Okay, so we are expecting to see steady rise in the bladder pressure, steady rise in the betrothal pressure, but no rise in the abdominal pressure because there is no straining. Okay, all are like going together, all are like smooth together. When the bladder pressure increase, of course, because of the betrothal increased pressure, the flow is going to start. The peak here is going to be along with the peak here, along with the peak here. And again, smooth decline until stop of the flow. She can control it. If I asked her to hold it, she can do it. And she can go again. In this part, we asked her to stop. Normally, there should be no residual urine in the bladder. The bladder is strong enough, able to evacuate herself completely. Okay? Normally, there would be no leakage or urgency with cough. So if I'm having coughing here, there is no leak. If I'm having coughing here or straining, there is no leak. This is a normal CMG. Let's see another normal one. This is how it would look, by the way. This is how it will look. So, if I'm having increase in the abdominal pressure, is that normal? It's not normal. If I'm going to urinate, why I'm needing to strain? So, I should see no increase in the vesical pressure, no abdominal pressure, sorry, no abdominal straining. Normally, yes, the bladder pressure is going to increase and the betrothal pressure is going to increase, of course, and I'm going to have a bell-shaped flow of the urine. That's normal. This is very normal. Okay? But if you are having something which is called overactive bladder or betrothal overactivity, from the term itself, what are you expecting to see? I'm expecting to see positive betrothal pressure in times where there is no urination. Like, for example, here, you are going to see the betrothal pressure here. And there is no urine coming out. You're going to see another activity here. This is what? This is betrothal overactivity or overactive bladder. Sometimes, not every time, you can have a leak here. Overactive bladder means that you are having the betrothal muscle that is working with no reason, just like that. It's contracting even if the bladder is not full, even if there is no desire to go to the bathroom. The woman is going to tell you, I have urgency, just like this, from nowhere. I was sitting with my friends and suddenly I got feeling to go to the bathroom. And after sometimes it went away. Just like this. This is bladder overactivity. Simply add this, okay? It's not going to come more complicated than this for you. If I'm having no urine flow or something that looks like this, a little bit increased in plateau, So there is something wrong with the urine flow. What do you think that could be? Give a hint. If the urine flow is slow, or it's very weak, or it's absent, what that would be? And the detrusal muscle is okay, and the blood pressure is okay. They are rising like this, but the flow is not normal. You should think about urine outflow obstruction or outlet obstruction, right? It's not something that has to do with the bladder. The bladder is okay. The detrusal muscle is working normally, but the urine is not coming out. So there is something obstructing the outflow. Okay? This would be the very common cases that can come for part 1. Something easy to diagnose, not something really difficult. Stress incontinence. Let's have an idea about stress incontinence. What is a stress incontinence? From the definition, stress incontinence is when the woman is having a leak of urine with straining, with stress. So when she coughs, when she laughs, when she strains, when she carries something really heavy and she strains, she has a leak of urine. So I'm expecting to see a rise here in the vesical pressure from time to time. Let me get the other pen. Here, I have a rise here and a leak here. With every, sorry, this is the vesical pressure. I need the abdominal one. Sorry. Here I'm having, for example, a cough. They say this is a cough, okay, this is an activity. When there is activity here, they are going to tell you that there is a leak here. It's going to be written, leak. This is what? This is stress incontinence. Okay, guys, is it simple now? I hope it is. Okay, next one. It came also, the ultrasound is showing intrauterine sac 2 millimeter in diameter. What is the expected beta HCG? So when you have this question, if you say it in the exam, you are going to ask yourself, am I going to remember the value of HCGs for every uterine sac? No, this is not the case. It's not about asking you about the memory of different numbers or the table of the values of beta HCG. This is not the question. The question is simply asking you about when are you going to see a very small sac like this, only 2 millimeters. There is a cut-off for the beta HCG to see a sac like this. So they just want you to know, or they want to know if you know the cut-off for the appearance of intrauterine gestational sac or not. Okay, for our college and the NICE guideline, the cut-off that we use for seeing an intrauterine sac is 1,000. If we have beta HCG over 1,000 and the uterus is empty, this is diagnostic for dilated ovum or miscarriage. You are going to have, you ordered a beta HCG for your patient, and it came out more than 1,000. Okay, and you did the ultrasound, and you have found empty uterus. There is no gestational sac. There is nothing. That means what? That means there is a possibility, of course, that this is an ectopic pregnancy or a miscarriage. How I'm going to know if this is not ectopic, or how to exclude ectopic pregnancy? If the beta HCG is rising or doubling every 48 hours, or at least increasing by 60%, if not doubling. Ectopic pregnancy usually have increase in the beta HCG, but less than 60%. Okay, so again, this question simply is asking you, do you know the cutoff for the appearance of intrauterine sac or not? That's it. They are not going to ask you about remembering numbers and tables and no. This is not the case at all. Okay, guys, a very important number to know about ultrasound cutoff is when you have the fetal pool measuring 45 millimeters. And again, they are asking you, what is the gestational age? They are not asking you about your memorization of numbers, no. This crown rump length in particular is very important for us. Why? Because when you have a crown rump length 45 to 85, this is the time when you should do the knuckle translucency. And this is equivalent to approximately 11 to 14 weeks. So simply when they are asking you, the fetal pool is measuring 45 millimeters. What is the gestational age? That would be 11 weeks, about 11 weeks. I'm sure they are not going to bring you 50 or 60s or 70s, because this is not what they are asking you the question. Okay, they are not examining numbers here. If they brought you 85, okay, this is a cutoff. 85 is
أكل
yes.
اقعد شوي.
Excuse me?
شو يا أبوي؟ كيف يعني مش فاهم؟
Okay, I thought you are asking a question.
ماشي يا أبوي هسه وقف. غيره شو بدك؟
Okay, guys, so if the crown rump length that come is 85, this would be 13 plus 6 or 14 weeks. Okay, again, we have cutoffs for diagnosing early pregnancy loss. That's when we are having a sac equal or more than 25 millimeters and no embryo, no fetal pool. Or we are having a crown rump length of 7 millimeters or more with no fetal heart rate. This is what? This is a miscarriage. This is a miscarriage. This is the diagnosis for miscarriage. Those are very important cutoffs, guys. And I don't think it would come more complicated than this. The very basics. Okay, now some biochemistry. I know that it's not the cup of tea for most of us. Okay, they love asking about the rate limiting step in anything. And I was surprised, honestly, when I saw this question coming in 2022. The rate limiting step in the synthesis of catecholamines. Because they usually, before, asked about the rate limiting step in glycolysis, glycogenesis, in lipolysis, for example, but not in the senses of hormones. But when I took a minute and I thought, why not? Why not? Especially catecholamines. Why? Why especially catecholamines? Because it has something to do with our practice. And I told you, sometimes you think that the question has nothing to do with your practice, but in fact, it has. It has something to do with our practice. How? We have many medication in our practice that work on this limiting step. And also we have some diseases that have, it's a TOG article, but I consider it as a guideline because it's very important. Phenylketonuria, for example. So anything that has any kind of relation to our practice, it can come in the exam. Okay, is this one is hard? No, it's not, if you know it. If you don't know it, then you have lost the question. Here we have a basic step for the synthesis of all catecholamines, which is the transformation of tyrosine to whatever. To the dopa, then to the noradrenaline, or the tyrosine to melanin, or the tyrosine to serotonin. So no, tryptophan to serotonin. So anyway, you need to know the precursors of catecholamines. If you know them, you can figure out the rate limiting step even if this is the first time you see it. Like, if you know that the dopa or the dopamine comes from tyrosine, so when you have the choices and you are going to find something like tyrosine hydroxylase or any other enzymes, you are going to figure out that, yeah, this could be the answer. Because I know that dopamine comes from tyrosine. Okay? But if you don't know this, then you have lost the question. So let's revise it. Let's revise. We have the tyrosine. Tyrosine comes from phenylalanine. We get phenylalanine from our food. Okay? And it's very important to convert the phenylalanine to tyrosine. Why? Because tyrosine is going to be the precursor for most of the catecholamines. The dopa, dopamine, norepinephrine, epinephrine. Okay? And that's why we have something called phenylketonuria. This is a disease, and not any disease. It's an important metabolic disorder that it is screened for in the UK. Every baby after he's born is going to have something called heel prick test. What is heel prick test? This one. We're going to take a sample from his heel for multiple of metabolic disorders, cystic fibrosis, and sickle cell anemia. Every baby in the UK is going to have this test in the first 7 days after being born, okay? So here, sometimes some people have deficiency in this enzyme, and this can come in the exam. Definitely. We have a whole top article talking about phenylketonuria. It's an old one. It's like a guideline. Phenylalanine hydroxylase. This enzyme, when it's deficient, the patient is not going to form tyrosine. And according to the level of deficiency, the level of severity of the disease will be. So if we have severe deficiency in the formation of tyrosine or severe deficiency of phenylalanine hydroxylase, the baby could have severe adverse effects. And it's inherited. This is an inherited condition. They can ask you, by the way, what is the mode of inheritance for phenylketonuria? Anyone know? The mode of inheritance that is common for multiple metabolic disorders. This is genetics. Also a recall, also an exam question. Most of the metabolic disorders are inherited by autosomal recessive. Autosomal recessive way, okay? So if the baby is having two carriers, his mother and his father are carriers, he can get the condition, Okay? And according to the activity of the enzyme, he is going to have the severity of the disease. He can have microcephaly and severe intellectual disability. He's going to have fair eyes and fair hair. Why? Because tyrosine also can be converted into melanin. So he's going to have deficiency in melanin and deficiency of dopamine. And if I'm going to talk about dopamine importance in our body, we are going to talk for hours. Okay? So this can come in the exam. This can come in the exam. And also this can come in the exam. And it came. This is the rate limiting step in the senses of catecholamines, tyrosine hydroxylase, or the conversion of tyrosine to L-DOPA. And because this came before, so we can expect anything to come in this pathway. I found this very beautiful picture for the pathway of catecholamines. I love it because it's related to some of the drugs. Forget about that this picture is talking about paraganglioma in the heart. Forget about it. I just need this. Okay? So they are telling you in every and each step where drugs can act. So here we have metyrosine that can block this enzyme. Here we have both sympathomimetics and MAO inhibitors in the formation of dopamine to norepinephrine. If you give sympathomimetics, it will increase the formation of norepinephrine. If you give MAO inhibitors, you are going to stop the conversion of dopamine to norepinephrine and also norepinephrine to norepinephrine. If you have inhibitors of norepinephrine uptake, we are going to block this channel. If you have calcium channel blockers, you are going to block this channel. All those can be used to control the excess of heart rate, the excess of excitability of the heart, the hypertension, of course. Okay, what else? Yes, the formation of tyrosine zutopa if we have excess tyrosine, and so on. Okay, serotonin, it hasn't come before like this, but they have asked it before about the precursor of serotonin. It came before in the exam. The precursor of serotonin is tryptophan. So, yeah, they can ask about the rate limiting step. Why not? The rate limiting step for serotonin synthesis would be tryptophan hydroxylase, or the formation of tryptophan to hydroxytryptophan. You got the idea, guys, I think. You got it, right? Okay. Here, the serotonin is going to be converted to 5-HIAA, or hydroxyindole acetic acid. This is also important. Why? Because the enzyme involved here is MAO, or monoamine oxidase. So MAO inhibitors are going to work here. So again, they can ask you this question. Because it has something to do with a drug that you can use, they can ask you about it. Okay. I just like to remind you of monoamine neurotransmitters. They are the catecholamines, of course, the dopamine, the norepinephrine, epinephrine, the serotonin, and histamine. They asked about the serotonin before, and they asked about the catecholamines. So the one left that they never asked about it, the histamine. Histamine is derived from histidine amino acid. And that's why they are called monoamine. Monoamine means that they came from only one amino acid. The amino acid that involved in catecholamines is what? Let's see if you are awake. What is the amino acid involved in catecholamine synthesis? Anyone? Tyrosine. Tyrosine, okay. Just to remind you, because they love the most common, the most, that the most common excitatory neurotransmitter, or the most common brain neurotransmitter, is glutamate. Okay, because they love the most abundant and the most common in the exam. Here, another one that has something to do with the rate limiting step, and again, very easy question that it's a shame to lose, guys. What is the rate limiting step in angiotensin II formation? It's in front of you. The formation of angiotensin I from angiotensinogen. Very, very old question would be, what is the precursor of angiotensin I? This would be angiotensinogen. Okay. A very old question also, a very old recall. What is the enzyme responsible for the formation of angiotensin I? This would be renin. Again, a very old question from like 2015 or something like this. What is the enzyme responsible for the formation of angiotensin II? This would be angiotensin converting enzyme. And they love to ask about the site of release of renin and the site of release of angiotensin converting enzyme. Okay, they love those questions. I'm afraid to ask if you know what provoke the renin release from the very beginning, from the kidney. What provoked the renin release? And please don't tell me aldosterone, because this is a very stupid answer. Do you know what stimulates the juxtaglomerular cell to secrete the renin? Hypotension. Hypotension, or the loss of fluids, or blood loss, or anything that can represent hypotension. When we are having hypotension or decrease in the blood pressure, this is going to stimulate the glomerular cells to secrete the renin. Renin is going to convert the angiotensinogen into angiotensin 1. Then this enzyme from the lung is going to convert from 1 to 2. Angiotensin 2 is going to work on secretion of aldosterone. And aldosterone is going to do the vasoconstriction, the sodium and water retention, and so on, to increase the blood pressure. Because this is a recall question, by the way, and I found aldosterone as an answer in the recall files, and it's really very silly. Okay, aldosterone is not the one that stimulates the renin release. It's the result from the stimulation of renin release. Okay, this one. This is also a recall. Which one more highly infectious stage of syphilis in pregnancy? Yes, the primary stage. Yes, this is the most infectious one. Excellent. Okay, this one. Which of the following arteries can arise from both internal and external iliac artery? If you have answered recalls, you should know this. This would be the obturator artery, guys. Okay, before we go there, do you know which is the first branch that comes off from the anterior internal iliac artery? This is also a recall question. This is the uterine artery. Okay, for our college, mainly, this is the uterine artery, but in some literature, there is a debate that the obturator is the first one. But if they are very specific and they said, what is the first branch that comes off from the internal iliac artery, that would be the uterine artery. Okay, and the end branch is also a common question. It can come in the exam. What is the terminal branch of internal iliac? What is the terminal branch for external iliac artery? I need you to memorize this page by heart. The level of division for each artery is very important. Okay, where the abdominal aorta is going to divide and where the common iliac arteries are going to divide. And it comes before where the internal iliac artery is going to divide anteriorly and posteriorly. That came before. And it came indirectly. They asked when the ureter is going to cross or be crossed by the internal iliac artery. According to my candidates, that was the question. And I told them that the ureter is always on the medial aspect of internal iliac artery. Always. Then the internal iliac artery is going to go posteriorly. And the ureter is going to go medially. So how this is going to cross this? And they said it was like this. So I told them that it has to be greater sciatic foramen. And it was there, the upper margin of greater sciatic foramen, because this is where the internal iliac artery is going to end. It's going to be anterior and posterior branch. And this is the only part of internal iliac that can be crossed by the ureter. If whatsoever, okay? This also can come in the exam. The course of the ureter is very important. Very, very important. Okay, the order of internal iliac to the ureter, to the vein, to the lumbosacral trunk, anterior to the sacroiliac joint is also very important. Okay, so I think that was a question. Let me draw it for you. The relation of internal iliac with the ureter and external iliac vein and obturator nerve. Okay, obturator nerve and the vein are on the lateral side of the artery. Medially, the ureter is here. Okay, this is medial. That came before. The relations to internal iliac artery. And the obturator artery, as we said, it's an early branch of anterior division of internal iliac artery, but it comes up from the external iliac artery also. Okay? There is a very, very old recall that was talking about which branch, I think from the internal iliac artery that could be absent. I remember something about, but this is a very, very old one. Do you know which one? Inferior rectal. Inferior rectal artery can be absent in some people. Okay, this one, I'm not sure why it looks like this. Okay. This graph came in the exam and they asked them what this part, the shaded part, represents. So when you have a look on the graph, let's see what the graph is talking about. It's talking about different pHs and the level of bicarb and the level of CO2. Okay, here is the pH, here, and here is the level of pCO2. Here, and here the level of bicarb. So you need to take a look at first to know where should I start? Where should I start? Okay, I'm having pCO2 here, increasing in the y part of the graph, and this is the x. This is the x part. Okay. So the y part is the PCO2 and it's increasing. Okay. And I'm having here in the x arm the bicarb. Okay. The increasing when you move up, they are increasing. Okay. And the pH, they said that here it's 7, here it's 7.2, here it's 7.3. Okay, so when I move down, it will be acidosis. When I move up, it will be alkalosis. So I know now where everything is going. I know now. And again here, they are telling 7.6. This is acidosis. So when I move to the left, it's becoming acidosis also. So moving up to the left, it's acidosis. Okay. And those were the choices. You need to choose one of those. The question itself is not difficult, but the interpretation of the graph can be intimidating, especially if it's the first time if you see it. Okay, and it took me a long time to get the graph according to what the candidates are explaining, because they didn't know what to say. They didn't know what they are saying in the first place. But it's not difficult. When you see something that's very new to you and you feel like, oh my God, what is this? Take a deep breath and try to think logically. The question is not hard. The question is asking me about interpreting the graph. I'm having here in the shaded part, they wanted this part. They wanted this area. Okay, I'm going to write down. You have a paper and you have a pen, you can ask for them. Here, I'm having low PCO2. Let's write it down. Will be better than this. I'm having low PCO2. Agree? Okay, in this area, I'm having low PCO2. Okay. And I'm having low bicarb. The bicarb is low here. And when we get up, it's getting more and more. So in this area, the bicarb is also low. Okay. Low bicarb. Okay. What about the pH? The pH here is low, and when I get above, it's getting higher. And when I come to the right, it's getting higher. When I'm coming to the left, it's getting lower. So I'm having a low pH, so this is acidosis. Okay, if you are going to attend my revision classes, inshallah, I'm going to tell you how to crack the APG very, very simply. I wrote down the results, my findings from this graph. Okay? So when I'm having a low pH, this is acidosis. Right? I want to know if this is respiratory or metabolic. Right, guys? I need someone to answer me. Does low bicarb means acidosis? Does low bicarb is going to give you acidosis? Yes or no? low bicarb can give acidosis or not? Okay, so what is metabolic acidosis? When we have high PCO2, this would be respiratory acidosis. When we have low bicarb, this is metabolic acidosis. And vice versa. When we have high PCO2, this would be respiratory alkalosis. When we have high bicarb, this would be metabolic alkalosis. So here, I need to know if this acidosis is caused by bicarb or PCO2. Low bicarb can give me metabolic acidosis. Okay, so this is metabolic acidosis. Why the PCO2 is low? It should be normal, right? Yeah, it should be normal, but here, it's not a pure case. This is not a pure case. This is compensated case. Why? Because the PCO2 is now changing. It's not normal. Okay? If the PCO2 is normal, this would be pure metabolic acidosis. Okay, if I asked you, let's say in another region, not the region they asked it for, and they considered this a tricky question because it takes time to think about it. Okay, if we have this area, let's crack it down. Let's write down the findings. Okay, the pH here is about 7.6 or something like this. It's more than 7.5. So this is acidosis or alkalosis? You tell me. Alkalosis. Okay, excellent. Yes, step by step. I like this. Step by step. Okay, so I'm trying to figure out where are we. So here we are in the area where the PCO2 is 50. They are going to give you the normal values, but not here. Not here. The normal values we're not giving here. I'm not sure really. But mainly in the questions of acid-base balance, they are going to give you the normal values. Okay? So here we have crossed the normal values for PCO2. PCO2 here is high. It's high. Okay? High PCO2. Normally, if I'm having high PCO2, I should see acidosis. Normally. Okay? So I'm going to write it like this and interpret the whole results at the end. Okay. What about the bicarb? Bicarb is low here and it's high here. So high bicarb. High bicarb means or equal metabolic, metabolic alkalosis. I should see metabolic alkalosis, and that's the case. So alhamdulillah, I know now why I'm having alkalosis. It's because of the bicarb. So this is a metabolic alkalosis. Okay, but why the PCO2 is high? It should be normal. Yes, this if it's a case of pure metabolic acidosis. But your lung now is working to increase the PCO2. By what? By holding breath. The breath is going to be shallow. You are not going to take deep breath. You are going to retain the CO2 inside. You are not going to exhale a lot of CO2. Why? To compensate the metabolic alkalosis. So this is a compensated metabolic alkalosis. I want to take a normal one. I want to try a normal one. Let's try this one. For example, this one. Let it be here. Okay. And I want this one. Okay, let's write it down without thinking any deep. Okay, don't confuse yourself. Don't confuse yourself. Write your findings down, then let it interpret itself. If you think about it just by your mind, you may get conflicted. Okay, I'm having here, I'm in this area. This area is what? Let me see. This area is where the bicarb is about 30. Okay, 30. Is this normal? Is this normal bicarb? Okay, let's start with the pH. The pH here is what? Is 7.1. So this is acidosis. Okay. This is acidosis. And I'm having PCO2 from here to here. All this range. This is high PCO2. High PCO2. So I'm expecting to see respiratory acidosis. That's what I'm expecting to see. Okay. The bicarb is within normal range. This is the normal range for bicarb. Until here, we have normal bicarb. If we get more, it will be high. If we get lower than this, it will be low. Okay. So this is normal bicarb and high PCO2 and acidosis. So that's why it's acute respiratory acidosis. Guys, is this clear or still difficult? Only the graph is intimidating, but if you think about it clearly and take your breath, you are going to get it. They are not going to write down those, of course. It just came without any labels, only the numbers. Only the numbers, and this part was shaded. Is it clear now? Okay, hopefully so. Okay, another question came before about the Haldane effect. And I don't know why many candidates have conflicts about Haldane and Bohr effect. Simply, Haldane effect explains the affinity of hemoglobin to carbon dioxide. Bohr effect explains the affinity of hemoglobin to oxygen. Haldane lung, okay? Haldane L lung. If this can make it clear for you. Haldane L lung, okay? What Mr. Haldane said? Mr. Haldane said that when there is more oxygen in the blood, there is high oxygenation of the blood, the hemoglobin is going to have lesser affinity to CO2. So it's going to release it, give it away, so that the lungs can expire it. But if you are having hypoxia, the hemoglobin is going to stick to the CO2. It's not going to release it. But Haldane mainly talked about the effect of oxygenation, not the hypoxia. Okay? We figured out that, okay, then the opposite is going to happen. But when he wrote his effect, he said, the more oxygenation of the blood, the lesser the affinity of the hemoglobin to the CO2, so the CO2 is going to be released in expiration. Okay? Bohr talked about the effect of CO2 on the tissues and the affinity of the hemoglobin to oxygen. Bohr wanted to release the oxygen from the hemoglobin to be delivered to the tissues. So he said, the more CO2 concentration or decrease in the pH when you have acidosis, okay? That means the lesser the affinity of hemoglobin to O2. So it's going to release the oxygen to the tissues. This is simply what the difference between Haldane and Bohr effect. And recently they love to bring it in the exam, and it's really easy. Just take care of the sentences. Just take care of the sentence, because the choice is going to be Haldane effect is the more oxygenation, the lesser the affinity, the lesser the oxygenation, the more the affinity, the lesser the oxygenation, the lesser the affinity. So with the stress and you are overwhelmed with the exam and so on, you need to close your eyes, don't look on the choices, try to write down what you know, then look at the choices and see which one is the right one. Just remember, Haldane, L, lung release CO2. So hemoglobin will release the CO2. So the lesser the affinity of hemoglobin to CO2 when I'm having oxygen. Bohr is talking about the tissues when there is acidosis or high CO2 concentration. The body is going to adapt to this acidosis and going to release the O2 from the hemoglobin to the tissue. Okay. This one is indirect question, but it's not difficult. During pregnancy, changes to 2,3-DPG will cause the O2 dissociation curve too. So first, I need to know what's going to happen to the 2,3-DPG during pregnancy. Anyone know? It's going to increase. And that's why it's going to shift to the right. When we have increase in the 2,3-DPG, it's going to shift the curve to the right. It's indirect question, but not difficult. And they love to ask about the oxygen dissociation curve.